On behalf of Dr. Kalyani Deshpande, she sends her apologies for not being here today, and I'll be representing her. I would also like to thank Professor Shetty for giving us the opportunity to present some of our work which was done when we were fellows back in Narayan Nethralaya. Well, the intention of this talk is just so that when we go back home, we are able to do exactly these procedures very, very simply in the clinic. So the biggest question that we decide when we look at a keratoconus is, should we burn or should we add? So if you're burning, basically we should have enough pachy to burn. So the primary concern is to look at the pachymetry, and which has been very well highlighted by Vishal, that if we have enough pachy, we do topo-guided treatment. If we do not have enough pachy, we do an Intacs. These are the rings, the various sizes, the diameters of the rings. These are PMMA clear rings. The indications are very, very clear. I don't even need to go into this. Now, we are going to stepwise see how do we go ahead if we are planning for an Intacs. The first question is the location of the cone. Now, if the most elevated area is in the central 3 mm, that means it's a centered cone. If it is not, then it is a decentered cone. Also, if more than 50% of the cone is in the central 3 mm area, it's a centered cone, otherwise it's a decentered cone. Now, based on that, we decide if it is a centered cone, it's a symmetric ring. If it's a decentered cone, it's a asymmetric ring. This is how we decide based on the location of the cones. Now, the second step is looking at the superior-inferior asymmetry. How do we look at that? We just look at 3 contiguous points above and below by dividing the corneal refractive map into 2 hemimeridians and then taking an average of them and deciding if the addition, if superiorly or inferiorly has a difference of more than 15 diopters, then we decide to place a single ring or an asymmetric ring. If it is less than 15 diopters, then we decide for an asymmetric ring. The next step is looking at the mean keratometry. Now, the mean keratometry, if it's less than 55, a regular ring, and if it is more than 55, a single an SK ring or a steep keratometric ring is what is placed. And this can be looked at any device where we take an average of K1 and K2. The next step is looking at the mean spherical refractive equivalent, and the simplest part of this nomogram is that you don't even have to memorize anything. It's just mention everything. Every single detail is mentioned on this table, and it's freely available on IGO. So based on the mean refractive spherical equivalent, you decide what is going to be the size of the ring, and that decides the placement of the ring also. Now, once we have decided of the size of the ring, the placement, if it's going to be asymmetric or it's going to be the SK ring, after that we go ahead and decide where to place it. Now, that depends on the site of the incision, depends on the steep axis. Wherever is a steep axis, you just, without giving it a second thought, just directly go ahead and put it in your laser machine that this is going to be where the ring is going to be placed. The most important factor is it has to be at the 75% depth at the 6 mm zone and not the thinnest point. So you draw at the 6 mm zones here, as we can, okay. So at the 6 mm zones, we just draw horizontal and vertical lines, and anything in that circle is where we decide what is the maximum, the minimum the pachymetry, and 75% of that. This is how the planning is. These are the parameters that are entered in the femtosecond platform. And this is how the ring placement is. Most of us have seen this. Now this is with the rescan machine where we had intraoperative OCT as well. So you open up the channels. Once the channels are open, it's much easier to slide the ring. This is a special forceps that is used for the Intacs. It's called the Brown's forceps. It's got an indentation in the center which allows the ring to snugly fit in. And we have to first hold the ring vertically and then guide it inside the channel. That is the only important step that should not be missed here, so that there is no inadvertent perforation. Also, there is no de-roofing of the channel. Now, this is just 1 or 2 case examples which we have seen before and after the ring placement. But ultimately, for the visual rehabilitation, as Vishal rightly mentioned, the contact lens or glasses are going to be the final stay. Now, after having decided if we do not have enough, if we do have enough pachy, what should we do? Should we burn? So how do we burn? the biggest advantage of doing topo-guided treatments is that you can provide a very good quality of vision. Again, the intention is just to sensitize the cornea for a better quality of vision. We are not correcting the refractive error. So what does this basically do is neutralization, normalization, smoothing. There are various methods, various names it is called by. We have published our article where we have, in addition to all the parameters, looked at the actual measure, that is the corneal asphericity, which is the Q value, which is the measure of irregularity. So what, it's a very simple nomogram. You look at the Q value, based on the Q value, if it is more than -1, you do not, if you change it, if it is less than -1, it is closer to normal, you do not change it. Step 2, if you have pachymetry, how much will you burn? Based on the pachymetry, you decide the spherical equivalent that can be entered into the device. Now, you take the device, we are using the Wavelight platform here, so it's got a Placido device with which we measure this. Now, this scan is not correct, so you would want at least a 5.5 to 6 mm coverage of the cornea. So once your scan is proper, this device exports either via the server or the flash drive. Now this is an interactive platform that we see here. So you have to check the quality of the scans. Once that is done, the Q value has to be entered. If the Q value, as earlier mentioned, it is more than -1, you bring it to less than -1. You have enough pachy. Based on the pachy, the pachy has to be after deducting the epithelium. So 475 was after deducting the epithelium. So after that, we get a subjective refraction, which has been already mentioned before. You also get a column which is of the axis. Now the axis has to be from the topolizer because we are correcting the topography. Then comes the modified refraction. How does that happen? You just keep the modified refraction as 0. Why do we do that? So this is when the refraction is fully corrected. This is when the refraction has been modified to 0. So if you look at this, even when you don't do a refractive correction, it still is causing some ablation. That means it's correcting the topography. Now you have to compensate for this. How do we do it? Now if you look at this, the central has got a 25 micron ablation, a myopic ablation. The periphery has got 43 micron of hyperopic ablation. The difference is somewhere around 18 to 20 micron, which accounts for 1.5 diopter. Now this 1.5 diopter is going to be induced as a myopia. So the patient will be a myopic by 1 or 1.5 diopter. Now this is just a rough estimate. Now this has to be compensated in the refractive error correction if you are planning for a near total refractive error correction. So this is what we finally get at the end of the planning. If you look at these are few case examples where we had retained the Q and where we had changed the Q as well. Now what's new in this ablation profile is that we are now able to do a customized, localized ablation, or which is a very, very minimal ablation, which is not touching any of the other area of the cornea, keratoconic cornea. This has been possible only with the Schwind Ameris till now, because it is able to locate which is your steepest point and then mark it. So this is what it finally looks like, the ablation profile. So it is just sort of chopping off the cone. So it gives a regularized cornea, and the epithelium sort of forms it gives a good scaffold for the epithelium to grow over it. So what we have done in this case is that we measure the long axis and the short axis and the centration of the cone, and you put this device, the data in the Schwind laser, and it just ablates only this area, and that's just about 70 micron trans-epi. That means 50 micron of the epithelium and about 20 micron of the cone. And this is followed by the conventional cross-linking. The periphery is of course scraped manually, and this is what it looks like. So preoperatively and postoperatively we can see a significant difference when there is significant flattening, and this paper has been now published in Cornea. Well, it has been recently accepted in Cornea, where they have found significant improvement in the visual quality as well as the clinical parameters and the keratometric outcomes. Thank you very much. I'll be happy to take any questions.